And welcome back to Moving Conversations. I'm Brian Ritchie. Joining me as always is Nora St. John. Good morning, Nora. How is it over there on the West Coast?
Spring is sprung, the grass is riz. It is becoming summer. All the hills are turning brown, and here we go. We're until it's going to be hot from now until September if things are like they usually are.
See, I was hoping it'd be hot today. I've got something to do tonight. It's going to be freezing out and drizzly. Oh, it's not going to be
Oh,
fun at all. But that's okay. That's okay. I did see we're going to be joining each other actually in person in a couple of weeks in Korea. Right around the same time that this episode launches, and it's going to be warm there, so it'll be in the upper 80s. So
and
it's going to be
humid.
humid. It's going to be
And it be
a scorcher.
soggy.
Yeah, it's going to be a little warm. I remember Asia in the summer is a little warm.
It
So
is. I was there last August, and it was hard. It was hard to walk around. It was just hot and
yep,
sticky.
I was as well. I think we were missed each other by a couple of
Yes,
days,
we
but
did.
yeah.
We're just.
Oh, it was nasty. Oh, so yeah, summer is definitely upon us. Uh, Last week we had an interesting conversation. We, took a look at a specific case study, a client of mine who has some neurologic things going on, and we thought, something that we haven't talked about, which not necessarily in the neurologic standpoint, but we were talking about Ehlers-Danlos Syndrome. And before we started recording today, and we said, hypermobility is something we haven't spoken about to any great detail. So it's a unique syndrome. It's not something
Yeah.
that everybody has. In my
Mm-mm.
career, I've seen it, a couple handfuls of times. It's not
Mhm.
something that I think you're probably much more likely to see it with, dancers and things like that than, general
Yeah.
population. But still, it's definitely out there. And with all the mobility stuff that is
Yeah.
out there today,
Yeah. Yeah.
it's like, okay, let's talk about this hypermobility issue and
Yeah.
mobility in general. So I thought, I agree. I think this is a great topic for today.
Well, yeah, I also wanted, before we go on there, I want to say we just mentioned that we're going to be together in Korea fairly
Mhm.
shortly. But I also want to mention that we've got a live event coming up, Moving Conversations Live with Brian
Oh,
and I,
yes.
September 13th and 14th at Blue Moon Pilates in Southern California. Again, that's in the show notes if you want to come join us. We'll spend a
Yep.
day on the low back. We'll spend half a day on the shoulder and half a day on osteoporosis. Big topic. And just try to get as practical as we can with you about how to work with it, protocols, safety, all that kind of stuff. So come on and join us. Again, you can find all the links and stuff in the show notes.
Well, the nice thing about coming to see this in person is you get all the practical.
Yeah.
So we can only do so much in an hour. So we usually in an hour or even 2 hours, if we do a multi, episode topic, we can only get so much into we're really into the theoretical. The practical, we can only do so much because this is an auditory setting for the most part.
Yeah.
We are on YouTube, but we're seated. We're not actually performing exercises like we do when we've done online events, when we've taught classes before. So this is a great opportunity for you to come on down, play with us, have fun, and get the actual practical application that you can do with your clients the very next day. I think that's what Nora and I are sort of known for, is what you learn on Saturday and Sunday, you can apply immediately on Monday. It's not esoteric. It's nothing that isn't ready to go.
Absolutely. That's our goal, is to help you be
Yep.
able to just take one more step up your ladder, get a little more confident, a little more creative with how you're working with your clients, and hopefully a little more effective.
Yep.
So with that in mind, let's start this conversation about hypermobility. And I'm
Yes.
going to start it with a couple things. One is, again, I've been doing this for over 30 years, and that was not a diagnosis I heard much 30 years
No.
ago. Really not much at all. And I worked with people that I think today would have been considered hypermobile for sure. They're
Mhm.
dancers and gymnasts, that kind of thing. But there wasn't necessarily a name for it. They were just, the loosey-goosey people you had to deal with a certain way. In the last, I'd say 10 years or so, I don't know about you, Brian, but like suddenly hypermobility and Ehlers-Danlos
Mhm.
have been like, I hear that so often now. And it's something that I really never really heard much of before at all. And now seems to be Just more, I think it's more in people's awareness. I don't know that the amounts of it have gone up or anything, but I just think it's much more in people's awareness that this is an issue, that hypermobility can be a problem. So I just wanted to kind of bring that up as
Yeah.
a foundation there.
It's interesting. We've both been at this for well over 30 years. And way back then, when we first started, there was strength training, there was
Yes.
Pilates, there was
Yes.
aerobics. And in my world of strength training, it was you did cardio, you lifted weights, and you did stretching. That was
And you went
pretty
home.
much the limited, yeah, you went home. That was pretty much the limitations that we had on us because that's what was out there. And I think much like a lot of things, I mean, if you look at a lot of different medical conditions in the last 10 years, we're hearing a lot more about a ton
Mm.
of different medical conditions,
Yeah.
more diagnoses. And I think the more we learn, the more we realize, oh, these symptoms could mean this. These symptoms could mean that. So we're getting a lot more diagnoses. So people are coming in saying that they have things like Ehlers-Danlos syndrome, and it's sort of an okay. And the first time I heard it, I'll be honest, I was sitting there and I was like, oh, sure. Uh-huh. Uh-huh. And, you know, with my left hand on my keyboard, I'm typing in what it is so I can glance at my screen going,
What are we
remind me
talking about
again what
here?
this is. Then I was like, hypermobility. I got this. But that was, like you said, about 10 years ago. And I was like, oh, yeah, but I've heard it a lot more. And I've had a lot more
Yeah.
people in the last few years come in
Yeah.
with it.
Absolutely.
And it's an interesting thing. Why don't we explain what it is a little bit?
Okay. So hypermobility, it's often called hypermobility spectrum disorder. And so there can be just somebody who's on the looser side in terms of their connective tissue. And that's, and everybody's got different, as you all know, if you've all been working with clients, or even if you're yourself, right, you may be a looser or a tighter body. So there's that. But there are some specific conditions which involve more than just being, a looser person. And again, there's this hypermobility spectrum disorder, which includes a whole lot of different components. It's not just that you're looser in your joints than most people are. It can certainly include joint hyperextension, a history of sprains and strains, and even dislocations and subluxations. Like that's, joint hypermobility. That's all part of that. But can also be accompanied by digestive issues. So it's kind of like the whole connective tissue of the body isn't working very well. It can be related to POTS. We mentioned this last time, postural orthostatic tachycardia syndrome, which is a dysregulation in the autonomic nervous system of blood pressure and heart rate. It can also be accompanied by bruising easily, by chronic pain, by vascular issues, and even by kind of things like uterine insufficiency or cervical insufficiency in pregnancy. So what we're talking about here is we're talking about a connective tissue disorder. Like that's kind of the fundamental thing of it. And just like we talked about bones and joints a little bit a couple weeks ago, the joint is held together by ligaments. Right? Ligaments are connective tissue, and ligaments are primarily other things too, but they're primarily what create the limits of how far that joint is going to go. And with a lot of the hypermobility syndrome disorders, the structure, literally the chemical structure of those ligaments is different. So it doesn't have quite as much stiff collagen, it's a little more relaxant, and it's just less tense and less tight than somebody else's ligament structure would be.
I'm not sure if you had anybody like this when you went to school, but there was always sort of one person in, either my grade or my class or one of the other classes that could bend their thumb all the way back and touch their forearm.
Right.
And, or bend the tip of their thumb and touch all the way back. And everybody go, ew. But now that I'm seeing that that's sort of on the extreme end, but that was happening when I was, in school. We're talking in the 80s. So obviously it's been around for quite a while.
I think just not diagnosed.
Not diagnosed.
This is a very simple kind of 5-point test thing for hypermobility. And there's 5 things. One is, can you lean over and touch the floor with your hands? So, lying, and a lot of people can. That's actually pretty common. That's not an unusual thing. Is there knee hyperextension? Also not uncommon. Is there elbow hyperextension? Also not uncommon. Then you've got this thumb thing Brian was just talking about, where you basically take your thumb and can you touch your forearm with your thumb? I can't quite do it. If you watch me on
Nope.
YouTube, I'm like, I can't make it. And if you bend your fingers, your wrist back, like how far do you get in terms of your finger motion? So basically it's like, can you take a finger and move it back to like 90 degrees? I can't at all. Like my fingers do not extend that far at all.
I was going to say a little bit, but not quite that much.
Yeah, no, I'm not, that's no way. Like even my most mobile one is not going that far. So basically those are like 5 simple screens, if you will, to determine if somebody's hypermobile. Now, once I started to do some research on this, I would play with this with a bunch of different people. And I would particularly check this out with my dancers and my yogis and my people that were on the mobile side anyway. And what's interesting was, again, these are all really functional bodies, so they weren't having any of the other symptoms of hypermobility particularly. But they all would have like 2 or 3 of these, but not all 5. Right? They might be a little hyperextended in the knees. They might be able to put their hands on the floor, but their thumb couldn't come down and their fingers weren't that mobile, something like that. So just interesting that this, and again, this is just like a very superficial screening situation.
I was going to say, because
anyway,
I know that for even myself, I can touch the floor with my, and my knees are slightly hyperextended, but I've had clients who can do both of those. And then they may have also like the elbows hyperextend, but they don't have the hands or wrist or thumb. So, it is interesting. But what I think these screens are good for us to know, if a client seems to indicate they may be having some pain, discomfort, or whatever for whatever reason, and you notice that they seem to be hypermobile, especially in some flexibility exercises, you may want to be able to do some of these screens and be able to say, you know what, I think maybe it's a good idea for you to talk to your doctor about this, because it's something that you may have, you may not, but it's something you may want to look at. I was just looking this up, and what I find interesting is it's much, much more commonly diagnosed in women, but underdiagnosed in men. Severely underdiagnosed in men. Men do have it. I have a client right now who has it, a male client. So I did find that interesting, that women are much more likely to have that diagnosis, whereas I think men, they don't really look at necessarily, or, it's just not as common maybe. So they're not being diagnosed as much.
So a couple of the things there's just hypermobility. And I've certainly worked with enough dancers and gymnasts and people who need that as part of, and yogis that need that as part of their career, to understand, like, mobility is often a good thing, and it can be a value in particularly in my world, a little less so in Brian's world. Like mobility is a value in Pilates, like, oh, you can stretch so far, you've got so much range of motion, or in the yoga community particularly. And this isn't just hypermobility. Like that's fine if you have no discomfort and you're just mobile. That's a wonderful thing, and enjoy it. The problem here comes in when there isn't really the joint stability necessary to keep the joint safe.
Yeah.
So, I've worked with, I'm thinking of a couple of yoga teachers actually that were distinctly, I'm sure they were hypermobile. This was before I was diagnosing people that way, or they were getting diagnosed that way. And the amount of pain they were in from the hypermobility, like they were kind of in chronic pain. And a lot of it was just because their joints were not stable enough. Their hips were hurting them all the time. Their knees were kind of funky. Their back was in pain a lot. And it was like they just didn't have the support from the muscular system, in their case from the ligament system, but then from the muscular system surrounding that at the end ranges. And then they were also encouraging in their practice more and more mobility.
Right. Yeah, I think that's definitely something that I've seen, because especially in certain fields, certain performance sports, flexibility, definitely, especially when working with some gymnasts, not only dancers, ice skaters, certain things where flexibility is definitely key, and they may have worked their whole life on flexibility, but let's face it, when you're very young, when people have more flexibility, if they can retain that as they get older, they may not even realize how unstable they are because they've been seeking that flexibility. But it's when you do have the pain, when you do have the discomfort, when those joints are unstable, when you have them do something that seems simple, like a step up and their knee goes backwards,
Right.
where you're thinking, oh, well, you're not stable enough. Or when they get into their 50s or probably even into their 40s and no longer performing at that high level, but they still have an overly flexible connective tissue in their body. And suddenly there's too loosey-goosey.
Like I think about the contortionists at Cirque du Soleil, for example. You think of that about, and I know like the Chinese gymnasts, the ones who can basically turn themselves completely into a U, so their head is essentially over their butt and they're in a back extension. Like that is a different structure of the joints. And I know, how they choose those people for that is they go around, or at least they used to go around different villages in China, test people out, take all those that were essentially hypermobile and then train them up. Like that was kind of how a lot of the Chinese circus schools work. But those guys, like that works as long as you are, and this is true for dancers as well, as long as you are maintaining the strength needed to support that. I had one dancer client who was unbelievably flexible in every direction. If she, for example, laid on her back and did like an adductor stretch, just like a split stretch, her legs would completely touch the floor. Like they'd even go, if she was on the short box on the reformer, her legs would go beyond the box. They'd go behind her. So there's a lot of mobility there, right? Really, really loose. And I'm sure she had, hypermobility disorder. But basically, when I was working with her, she was kind of early in her career. And what we did was we developed essentially a strength-only training program that she did for 2 hours every day. Like she would come in to the reformer studio, and she also had some other work that she did in the fitness studio, and she would just do strength for 2 hours every day. And she became, like, I think, a soloist of Pacific Northwest Ballet, very successful dancer. But that was what it was required to hold her together enough to be able to perform at the level she needed to perform at. She had, and she didn't do any stretching at all, ever, like ever. She would do what she needed for sport, but nothing else.
Right. I'm going to ask you a question. When working with clients, if they're yogis, if they're gymnasts, if they are dancers, whatever, and they have this flexibility, I tend to see people lean into exercises that they're good at and want to do those more and more than the exercises they're not good at. So the people who are hypermobile or really, really flexible love to stretch. They think that is the greatest thing in the world. And they're the ones who spend a long time doing it. And they will do mobility exercises like crazy. But that's exactly the wrong thing that they may need, maybe, in order for lifelong, bodily support, connective tissue support.
Absolutely. And this is where, like, when I'm working with somebody like that, and I'm thinking of a bunch of people that I've worked with, or I think of a lot of the yogis that I know.
Yes.
Right. They are yogis, and they've chosen that because they're good at it. Right. I mean, I think of somebody like my husband, Al, who is stiff as a board, like mobility is not his thing. We'll just put it that way. And he would, like, he's done a little bit of yoga, but like he would not be inclined to fall in love with yoga because it is completely challenging for every joint in his body, right? So the people that are attracted to yoga are often the ones that are already mobile anyway, and they just increase that. But there are ways, and certainly yoga taught well, because I want to make sure we're not bashing yoga here. No. It works a lot on finding the support for the joints at the end range. And that's kind of where I want to guide us in terms of principles with clients who are very mobile, is rather than hanging out passively, let's say in an adductor stretch, like I was mentioning earlier, in the reformer, I'd be feet in straps, big adductor stretch and hanging out there and chatting, like work that range. So come up a little bit, come down a little bit, come up a little bit, come down a little bit. Find that work at those extreme end ranges to create the support around the joints. Nice. I know I've done a ton of work with that in all different elements of clients who are on the hypermobile side is really worked on find those end ranges and work them in the end ranges with some resistance. So they've really got to get the strength to support that joint appropriately in those ranges.
But remember, at that end range is also where they're going to be the weakest. So we can't overload it.
Yes.
It's
No.
sort of, you really have to be careful at those end ranges because you don't want to pull them beyond their range of motion either. So that's just a reminder that, you know, start light and work your way up, but understand that that's extreme ranges of motion are where we're normally at our weakest.
Right, and that's also where, and that's why I find those ranges gently, carefully, and then slowly try to build up the strength in those ranges. One other thing that I want to mention here is, and this is one client always sticks in my mind when I talk about this topic. Just because you have hypermobility spectrum disorder or even Ehlers-Danlos doesn't mean you're loose everywhere.
Yes.
So, and this is what gets very confusing for people. And I use this one example of this client that I had who was very tall and kind of on the lean side. And her hip flexor mobility was the most I've ever seen. So if she, let's say there's something called the Thomas test, you basically lay on the table and you drop your leg back behind you. She had almost a 45-degree hip extension with her leg behind her. Like it was, I've never seen anything like that, even in my extreme dancers. So she was loose there. She had kind of that collapsed posture because she was very loose in her spine, a lot of range of motion in her arms and everywhere else. But her hamstrings were so short that she could barely touch her middle shin with her fingers when she did a forward bend. And you know, when I looked at her, it's like all she was doing, she's holding herself together with her hamstrings, period. Right. So that muscle had decided that was what was holding her posture together because everything else wasn't doing its job. And so look for that. If you've got somebody who's hypermobile or somebody who's just tight in weird places, like they're really tight here, but they're really loose there, that can be a sign of a hypermobility spectrum disorder. It's not always going to be somebody who's loose everywhere. So just a reminder on that.
Well, that was what I was going to bring up. I'm working with a client right now, a golfer, male, who has EDS. And what was interesting is when he told me this, he came in with a very specific injury, mid-back TL junction, tons and tons and tons of pain. Could not stabilize it to save his life. And he's a golfer, which means what? A ton of rotation.
Right.
And, you know, every golfer, anybody who's worked with golfers, they're trying to get that extra 5 yards, 10 yards. So you swing a little harder. And what happens is you can't control that end range of motion. So the club swings you around and then you're wrenched to that end range. And he was having some issues. But when he said he had EDS, I did a bunch of different tests on him and I'm thinking, interesting. Certain muscles, absolutely. Certain joints, no question. However, there were others that were so tight.
Yeah.
That was just, I kept thinking, are you sure? I know your daughter has this and, you know, I've never seen her before, but okay, I totally agree. And this can be very genetically based, but I was thinking, are you sure you have it? But then I'd see his other joints would be, oh, wow. Yeah, you really are. For a male, you have incredible flexibility here, here, and here. But these other areas, you are so tight. So it really had to become, okay, how can we teach the body to decelerate at those end ranges? How can we train the body to still develop power, but not sort of hang out at that end range of motion? Just imagine that adductor stretch you were talking about. You put weight on there and all of a sudden you just go wham to the end range. Well, eventually the muscle and the joints are not going to like that.
Right. Exactly. So especially if you've lost joint congruency because those ligaments aren't holding that bone where it should be in the joint. We talked about this a little bit in our bones, right? Like, and that's the challenge with hypermobility is that joint is not working well. It's not necessarily, it's going to wear itself out more. It's going to have more mobility than it should. And it won't necessarily be moving or gliding the way that we want it to.
Yeah. So it's interesting working with him because he still needs rotation. He still needs it because what I found is he became so hypermobile at that one joint that actually his other joints were trying to stabilize him and overstabilize. So the rest of his thoracic was actually quite stiff in comparison to
Yes,
sort of like a 2 to 3, segment of the spine that was really hypermobile and everything else was really quite rigid. And I thought, okay. So again, retraining and saying, okay, what we need now is stabilize the heck out of this for the next 6 weeks. And then begin to introduce a little bit of that rotation in the entire spine, but really stabilize where he was unstable, focusing on that. And then sort of sneaking in, okay, because he's a golfer, he still needs that rotation. And now he loves rotation because the rest of his spine actually moves the way it's supposed to,
exactly.
so he's
Yeah.
able to stabilize where he needs to.
So I think that gets to kind of the principles of this, which is, number one, identifying where they're loose and where they're not, if that's the case, like it is with your client or with my client, and then really trying to balance that out, because in both these situations, there's extremes. Like one area is really, really hypermobile, and so another area is really, really, really hyper tight. In order to balance that, and instead, like with my client, I worked a lot on some hamstring mobility, but I worked a lot on strength for her, because she was just loose everywhere. So we worked on core, like just Pilates. We did arm strength and core strength and back strength and side plank work, and it made such a huge difference just to get the strength in the rest of her body and the ability to support her posture in the rest of the body. Then those hamstrings could actually start to soften, because until something else was taking the support, those hamstrings were not going to let go.
Yeah.
Right. And same thing with your guy, with the golfer. That's a great story. You had to get that area stable enough so the other parts could let go a little bit, because the body's doing whatever it needs to do to be as efficient and safe as possible. It's not always making the best choices, but it's doing the best it can.
I'm thinking of another person I worked with who was, I'm not going to call her a yogi, but she taught yoga. She also taught Pilates, but yoga was really her thing. And she actually asked me, she said, would you watch me do my postures, my poses, and correct me, see if there's anything that I need to do? And what I found, because I'd never really studied a lot of yoga, I've done some, but my body and yoga just don't agree for whatever reason, never did. It's okay. I like Pilates a whole lot better. It agrees with me. But in watching her, I realized how much she was sort of hanging out on her ligaments rather than using her muscles.
Yes, absolutely.
How and like tree pose where you're standing on one leg and whatnot, her hip was slung out so far to the side that she was really, she could hang out there for a half hour. I said, yeah, but there's no muscles working. That's your IT band and your hip ligaments and your spinal ligaments just holding on for dear life.
Yes.
And I find that a lot of people with things like EDS and hypermobility in general have a tendency to do that. They rely too much on the connective tissue, much more than the muscular system.
Right. And that's exactly the case. One thing I say a lot is when somebody, for example, has very hyperextended knees, and you're trying to correct that for whatever reason, or trying to improve that, the body wants to be efficient. And efficiency, the ligaments are much more efficient in terms of the body than the muscles. Muscles take a lot of energy to work. Ligaments, not so much. So if the body wants to be energetically efficient, what it often does, hanging out on those ligaments takes the least amount of energy to support.
Makes sense.
And I mean, y'all know this. If any of you are sitting, in your car driving right now, which I suspect some of you are sitting somewhere else, I bet you're slumping a little bit. I bet you're kind of relaxed. And if I said, hey, why don't you really sit up straight, find that posture, bring your shoulders back, I bet you'll hold that for, another little bit of this conversation, and then you'll give up again, because it takes energy to hold that posture.
Yep.
Right. So that's where, again, with yogis, with my Pilates people, with my more mobile folk, it's like, okay, well, you've got to use more energy than you're used to. You've just got to get stronger, create more strength and more endurance in the muscles around that joint at full ranges. So starting from small ranges, like I usually keep the ranges really small when we start, like thinking of feet in straps.
Yes.
Right. Don't go wider than the reformer. Keep it all really small. And then as they get stronger in those non-end ranges, then we'll start to build up towards end range.
Yeah, that makes a lot of sense. For me, especially, is you've known me for many, many years. I'm big on stability because for a lot of one of my specialties is lumbar issues, spinal issues in general. But I find that teaching someone to be stable first can create the strength they need so that we can now work on mobility afterward. I sort of have to
Safely.
start somewhere, you
Hmm.
know, and I always found that stability is a place where they could, because again, if someone's in pain, the last thing that they're going to want to do is go into extreme range of motion. Their body won't let them oftentimes, but they
Right.
will let them strengthen at that neutral position and then begin to work our way out. So I think the same philosophy, you start
Yeah.
with getting them stable, you start small, and you begin to work that out a little further. Now, something that our listeners are going to see a lot of, and I'm sure you have seen a ton of this on Instagram and Facebook and everything, are all these people doing mobility exercises because it's huge right now. The topic is huge.
Hmm.
We're about to have a big conference this summer, and one of the tracks is actually mobility. I'd never
Hmm.
seen that before, but the whole track is on mobility only. And again, if I was working with an athlete, maybe that is something that they need to work on, perhaps based on their sport or their, love, their passion. But when you see these people doing these things on Instagram where they're bent over at 90 degrees with a stick behind their back and they're turning their body so far that the opposite hand is reaching way past the opposite foot and their body is turned so that they're almost looking at the sky, I'm thinking, I'm not an owl. My body's not supposed to do that. I'm just not. But that's kind of what I'm looking at. I'm seeing people who are doing things because they can. And again, if
Yeah.
they're athletes, they're strong enough at that moment. 20 years from now, they may not be. But again, I think that's a disservice to a lot of people as well, because you're really focusing on something that people may not be able to achieve. And even if they are, is that really what they need? If they can go that far, maybe they don't need additional mobility. Maybe they need the opposite.
Which brings us to this whole topic, right, of mobility versus stability, what's right for your body. And I think this is a really important piece of this conversation because again, I feel like fitness has discovered mobility, right? Like, woo, I mean, you know how that
Like
is. Like, woo,
there.
it's a thing. We're now discovered mobility. Okay, great. And if I was a 20-something track and field athlete, running, mobility might be really, really helpful for me.
Mm-hmm.
It might really make the difference in terms of being able to get more mobility, more in my hips, to get more power and strength through my drive, for example, for my gait. That's possible. If, on the other hand, I am a already hypermobile woman who was a dancer and or a yogi, and I like mobility because it's easy for me, that
Mm-hmm.
isn't necessarily going to serve me in the end, the end of times. And something I say a lot, so don't take this the wrong way, but a tight joint is often a less unhappy joint.
Yeah.
The clients I know that have the least orthopedic issues, musculoskeletal issues, they're not the loosest bodies on the planet.
No.
I mean, they're not always super tight either, but they're often kind of like in this nice in-between range where their fingertips can maybe touch the floor, touch the top of their feet, and they've got some range of motion, but it's not extreme, and their joints are very stable.
Mm-hmm.
And honestly, that's a pretty healthy body. So to Brian's point, stabilizing those joints is a key piece of, number one, just improving, I think, overall function of the body. I think creating joint stability is really key, period. And it also creates awareness because in that joint stability, I'm always working on joint mechanics. So it's not just, hold that joint together, but it's how does that joint move in an appropriate range that the body can well support.
Yep.
Right? Because that's really like I think dynamic stability as opposed to just, lock and load stability is critically important for, again, everybody, but particularly if somebody's hypermobile, we've got to really create that dynamic joint support. So they've got range, they've got strength through their whole range and support through the whole range.
And I love that you use the term dynamic support. because like you said, lock and load is one way that you can do it. Absolutely. And it's something that we used to teach long time ago with bracing and all that. Just hold it and don't move it ever again. And we realized real fast that's not very functional, and you're not going to get any stronger. It's a very temporary situation, because as soon as you go to move, well, you don't have the strength necessary to move dynamically.
Yes.
Which is why when I teach stability work, I added a fourth stage, which is dynamic movement, because you need to be in motion. You need to have dynamic movement and not just be overly stable all the time. And I think that's very important to be able to work through range of motion. And I love to use the word explore their range of motion. Where are they strong? Where can they still maintain that stability through that range of motion? Like, I'm going to use my arm, for example. If I tried to reach my arm behind me, there's a limit as to how far back I can go. Well, some people can go a lot farther. So I want to look and see, where are they still stable in their range of motion? Where can they still have some strength? And when does the strength just go away and suddenly they're just sort of loosey-goosey and wee all the way back?
Yes.
Because that tells me, okay, they have a strength level to a certain point, and maybe I don't want to exceed that right now. Train up to that, and then go a millimeter further, and maybe go a millimeter further with strength to begin to bridge that area, if possible. Some people can, some can't, but if possible.
Absolutely. So that's that idea of finding, and I think just to wrap some of this together, right? We've talked about identifying where they're mobile, identifying where they're tight, trying to balance out the tightness and the weakness. So, or the tightness and the hypermobility. And then also looking at joint mechanics, like you're just kind of talking about. It's like creating stability with the joint mechanics that joint needs. So in the shoulder, for example, that can be working for medial and lateral rotation, like basic rotator cuff work in the shoulder. But doing that while making sure that humeral head is staying in the joint. Some people, if they're super loose, they roll that forward, that whole humeral head slides forward. They roll it back, that whole humeral head slides back, and it's sloppy in the joint. So it's not just working on the movement and the strength, it's working on the joint mechanics to make sure that stability is working through whatever range of motion they need, right? Whether it's hips or shoulders or ankles or wherever else.
Yeah. So when it comes to mobility, all I'm going to say, to sort of, I don't want to say to cap this off, but work within someone's natural range of motion to a certain degree. Figure out, like you said, I love the thought of where are they tightest, because big muscles, our big outer muscles, have a tendency when they're dysfunctional to tighten up. So, someone who is round shouldered may be tight in their pec, but if they are, loose in the joint, you go to stretch out that chest while that muscle is tight. Suddenly the joint isn't working properly. And even though the arm can go back as far as it wants, it's really the humeral head that's moving around. So we really have to be careful and watch how they're moving. And I think you and I both sort of do this naturally, and hopefully everybody does. But my thing is, I want to look at the body and be aware of something that doesn't quite look right. When you look at them and their body is moving and you're like, there's a hitch in that giddy up, even though they're moving right. They're sort of moving right. Their arm may end in that right place, but their shoulder's not moving the way I think it should. So that to me is sort of an assessment that I go through, that think, okay, there's something going on in there that may not be 100%, that maybe we need to focus on more stabilization within the joint of the smaller muscles of the joint before I start working on stretching the larger muscles on the outside, if that makes any sense.
Absolutely. No, absolutely. It's looking again at observing joint mechanics. And I know if you're a new trainer or somebody who's a client out there, like you're like, what are you talking about observing joint mechanics? Because it's not always obvious. But once you've worked a little bit while, you look at things and you see what looks harmonious, what looks like the joints are moving in harmony with each other in a good integrated way. And sometimes you look at it and go, what is happening there? The things are clearly like one part of the whole complex is moving much more than another part. And that's where you kind of focus in and say, okay, so I've really got to, in Brian's case, really work on spinal mechanics. I've got to work on stabilizing the TL junction, the thoracolumbar junction, and then mobilizing the upper thoracic, right? Or the rest of the thorax. And everything else that goes with that, the rib cage and the shoulders and how everything's working together. And that's where we're looking for that harmony, that integrity of the whole system to move together. And with hypermobility, you're often missing a whole bunch of pieces of that.
Yeah, I love the term harmonious because that really is what you're looking for in movement. And when
Yeah.
you see somebody move, you can always spot someone who isn't moving quite right.
Mm-hmm.
And again, it's not our job to diagnose necessarily anything, but you can always see when someone's not quite moving correctly. And you can say, okay, something's going on there. It's at least should be your first indication that maybe I should take a deeper look.
And I was for a long time I lived in Oakland, California, and I lived right near Lake Merritt, which is a big lake there, and people would always be running around the lake. So I would take a walk around the lake, or I'd be running myself around the lake, or else I'd sit on a bench and just watch people go by, like watch the things. And even an untrained eye, so, if you're not an instructor, if you are a new instructor, just watch people move. And you'll recognize that there's people that move very gracefully, that you'll notice that. There's some that move kind of fine, and you'll notice that. And there's some where something sticks out. Like you'll catch, like somebody will be walking by you, for example, and there'll be something funny about their gait. It'll catch your attention because there's a lack of rhythm. There's a lack of harmony. And that's usually those training your eyes to those lacks of harmony, or that lack of integrity.
Yep.
A couple of the things that I want to say about hypermobility spectrum disorders is they're often genetic. So particularly Ehlers-Danlos has many different components. There's like 13 different versions of it or more. And most of those are genetic. The hypermobility version of EDS is actually, they're not sure if it's genetic yet or not. There's still some debate about that for whatever reason. So it can be a strong genetic component. So if your parents, brother, sister, grandparents are super loose, then that might be something you want to think about. The other thing too is a lot of times this does have these other autoimmune components to it, which can be fatigue, which can be flare-ups, which can be kind of chronic pain oriented. So I just want to bring that other piece in there, because EDS isn't just about hypermobility. It's often about these other symptoms that people have as well. So if you're working with somebody with that, we talked a little bit about this last time with Brian's client in the case study, when there is an autoimmune condition, that can really change how somebody shows up each day. Yeah. Some days they're great. They got a lot of energy. They're good to go. Some days they come in and they're just toast. They're just worn out. They don't have the energy. They're just not up for it. So there's a flexibility that I think is really important when working with somebody particularly with EDS or a more severe hypermobility spectrum disorder. Just to say, hey, if you can't come in, if you really feel crappy, let me know. You maybe have a flexible cancellation policy for those clients, because you know that they're going to have some good days, they're going to have some days when they can't get out of bed or they can't really get there. So just being aware of those other elements.
We said this last time with the client that I had with dysautonomia, where sometimes it's going to be taking a few steps forward and then 1 or 2 steps back. You're going to see that with someone in this situation, especially what I've read is that EDS, they have a higher likelihood of an autoimmune issue down the road, possibly. That it's
often associated.
Yeah, it's not they'll definitely, but it's often associated. So there may be something underlying that's not rushed to the surface yet, that may be there, like a rheumatoid arthritis or a flare-up. If there's an area that seems to be flaring up regularly, you may want to get them to go in and see a rheumatologist or something. But it's definitely something that we can be aware of because we see them on a regular basis.
Exactly.
And when you're looking at your own body in the mirror, you never change. And if someone hasn't seen you in 10 years, they're like, oh my gosh, have you aged? And it's the same thing. We see someone a couple times a week. We know what their body does each session to session. We have something to compare it to. If we're taking notes, we should be able to see strength-wise, flexibility-wise, everything. And if they come in and something's just not right, or they start heading backwards a little too often, that's something where we may be able to say, maybe go and see a rheumatologist, maybe go and see, or like their hands start flaring up on them. Yeah, my hands for some
Mhm.
reason, or one of the joints that's more common for something like rheumatoid arthritis,
Right,
you know,
hands, feet, ankles.
hands,
Yeah.
feet,
Yeah.
where they're going to say, they don't feel quite right. It's like, you know what? Why don't you get in to see somebody and just make sure that there's not something else going on. Like I
Yeah.
say, you have to be
Yeah, good
flexible
point.
with what you're doing, in that you're going to have those days where they're going to come in and it's going to be, okay, yeah, you blew it. My EDS client, the golfer, he called me up and he said, you know what? I played too much and I don't know what I did, but the next day I was in so much pain. It felt like I was right back to where we started. He's like, all right. And I said, we're going to take the day off. We're not going to do anything. And he is a type A personality. He's like, but I need to exercise. I said, no, you don't. You need to calm this down. And guess what? He was able to calm it down in a couple of days. And
Yep.
it's taken us about a month, but he's right back to where he was,
Yep.
strength wise. And he's like, no, I feel great. And his exercises, he's able to do things. And even today, I saw him this morning and he said, man, we did a bunch of new stuff. He said, I feel great. I was able to do all of this. And when he leaves, he feels better than when he came in, which is also another positive sign for me, at least.
Absolutely.
So it's
Absolutely.
like, all right, you're on the right track. And I have to get him out of his head because, he's always looking for, am I hurting? Is that hurt? Is that, that's common with certain
Yeah.
injuries,
Yeah.
so it's like, okay, I think we need to just let that go. Your body's doing good now. Now we just need to move forward.
One other thing, which I think is important about this, is hypermobility. That there's one other piece. One is that hypermobility, particularly in women, will often change during, like, when they first start their periods, during
Mm,
pregnancy, and during menopause.
really?
So the hormone changes, hormone changes definitely affect connective tissue. We kind of know that from the
Mhm.
menopause work. And so they'll sometimes feel like things change during those periods. And so those are just important times. If you're working with a woman who's hypermobile, just be aware that those times are particularly vulnerable. They'll often get more hypermobile,
Okay.
particularly during pregnancy when relaxin is kind of going through the
Mhm.
system and things are starting to loosen up. So just being aware of that is an important thing. The other thing too is this is not generally progressive in the sense of other diseases, but it does mean it may need lifelong management,
Mhm.
which isn't something anybody wants to hear. But this isn't like an ankle sprain where you're going to do some exercises for 4, 5, 6 weeks and probably be good to go. This is something where ideally these clients will be doing some sort of regular strength work, physical exercise regularly, possibly for the rest of their life, to really manage this well. So I think that's just something to create expectations with your client. Like, yeah, we're going to get you, we're going to improve things, but the chances are good that you will need to keep doing some kind of maintenance to keep those balances going in your body. That if you really let it go and you don't do anything for a while, you may go right back to where you were when we started. So I just think that's an
Yeah.
important piece to bring up too.
And that's interesting about it not being as progressive. Yet, something to keep in mind is as we get older, we have a natural loss of strength, sarcopenia, things of that we want to
Right.
make sure that they don't take a prolonged, pause of exercise, especially their strength building, because that's so much harder to gain back when
Yes.
you've gotten to an advanced age. So
Yeah,
if they've
absolutely.
established that standard, that baseline, that they're doing a half an hour of strength work every day or whatever it is, that they maintain it and they keep it. Because those clients who do drop off for a period of time, it is so much more difficult to regain that after 70, 75 years of age.
One last little piece I want to mention here, and this is something that I've experienced with a few different clients, is when there is hypermobility, there is also often a lack of proprioception.
Hmm.
So there's something about, and this actually makes sense from this is how I explain it to myself. So take this for Nora's explanation, which may not have any validity in actual science. But our body creates motor control and creates movement patterns based on feedback from our Golgi tendon organs and our muscle spindle fibers, like where our body is in space is a brain map that essentially we create through life. And when you don't have a stable joint, that brain map gets fuzzy. Because in fact, every time, let's say someone's got a super loose shoulder, every time they reach their arm up, they may be doing it slightly differently. Whereas somebody with a tighter structure, there's going to be a very consistent, like I lift my arm this way and it goes in that pattern and those muscles fire at exactly that same way. And that creates, this is again, my sort of image of this, that creates a stronger proprioceptive map in the body. Right. When that joint, on the other hand, is kind of never quite in the same place. And so they're doing the activity, but they're not necessarily doing it the way, in a different way each time. That proprioception is way less clear. So one of the things that we've worked with in terms of hypermobility is how do you increase that sense of understanding of where they are in space? Right. So closed chain work can be super important because that gives you a lot more feedback in the body. So rather than, let's say, feet in straps, you might want to do a standing on one leg, moving the other leg for getting those abductors going. You may want to do some all fours work for the arms rather than doing kind of more open chain or upper body work. So closed chain is really important. Also, sometimes using props like a ball between the ankles or a band around the knees so that they can feel something, like feel where their body is in space more strongly. This is something, we actually talked about this as being another topic for one of our things is, how do you optimize proprioception? How do you get people to feel what you want them to feel? And with hypermobility, that's a really common issue. One thing too that I know, this is just my own personal experience, but I was a dancer for a long time, and then I started studying Tai Chi and different martial arts forms. And the interesting thing about those was I was not at end range of motion. A lot of those motions are very much, not at end range. And I realized I didn't really know where my body was when it wasn't at end range. So it was just like a lack of not that I didn't work, not in end range, but like that sensation, you get so used to the extreme sensation of being at your end range all the time that the subtler sensation of not being at end range took me a little while to really tune into. So, and I think that's very true with hypermobility is like they just don't know where their body is because again, it doesn't have a solid kind of motor control pattern inside the neurological system and even in the joint system.
That makes a lot of sense because I'm thinking back to a couple of clients that I've had with EDS or just hypermobility spectrum in general, and thinking, yeah, they had a hard time. Things like they snapped their knees when they would do any type of squatting or lunging. Just they didn't know how not to, and you'd say, "Don't do that. Don't do that. Don't do that." And it wasn't that they'd say, "Well, I'm trying." It's just it kept happening. And it's interesting that, you almost have to slow them down and keep their range of motion a little smaller and get them to really be in the moment and present on how their body feels and really re-educate where their body is in space. So that's really interesting.
Exactly. Yeah. And that's something that I think of, 3 or 4 different clients, I've really had to work on that. Like this one that I mentioned earlier with the super tight hamstrings and the very loose hip flexors. In her case, when she, let's say, lay down supine, was doing footwork, her natural posture was extremely posteriorly tilted, as you can imagine, because her hamstrings were like so tight. So in her case, I don't usually do this, but in her case, I put like a supported neutral under her low back to give her a curve.
Yeah.
To try to make the low back and the pelvis and the legs all work the way they should instead of staying in that posterior tilt that was her most natural position. And so I was like giving her feedback about this is where I want your joint to be. Or things like, with feet in straps, opening and closing. I would set this up, it's more on the trap table, but I'd set this up so they hit something before they got to the end. Maybe it's my hands, maybe I'd piled up a bunch of stuff, but basically like, oh, that's the end. Oh, that's the end. Like they had to have those external tactile cues, visual cues, auditory cues to try to understand where they needed to be.
Those are great tactile cues that they could feel externally. It's not just telling the joint where it is in space, but they're getting it through wham. Okay, that's as far as it goes. I understand that.
Right.
So no, that's great. I love that idea.
Like I'm also thinking about your guy who, did the squats and then the knee snapped when he straightened up, right? He just kind of
Yeah.
locked back. Like because I worked with that with a lot of my dancers, and I would put, like you do for getting the VMO to fire, I'd put a band around the knees, right?
Mm-hmm.
Like just around them. So when they come up, they had to feel that resistance at that end range,
Mm-hmm.
right? And I'd
Mm-hmm.
say, okay, now, stop right there. Stop right there. But I had to give more feedback.
Yep.
Because that lock back, that's very unconscious. That's really hard to
Yeah.
bring to somebody's awareness.
Yeah. Yeah. No, I'm already thinking, okay, next time I work with these people, I've got some ideas of trying to create some of that tension for things like that, because now that makes a lot of sense, giving them that cueing that's external
Yeah.
instead of always
Yep.
internal. No, I love that.
Yep.
That's great.
Yeah. I mean, when the insides, and this is true with clients that are just not very bodily aware, which we work with all the time too, right?
Mm-hmm.
Like, how do we get them to feel something that we're trying to get them to feel? Because they're doing something automatic, and you want them to have a little more awareness. And, what do you do to make that happen?
Yeah. Fantastic. I love that we're ending on something that's so practical and so easy to do for our clients. We covered a lot today. We covered a whole lot of information on hypermobility spectrum. Is there anything you wanted to add before we wrap this up?
I think some of it is just bringing it to the awareness of both the clients and the instructors out there to not
Mm-hmm.
assume that mobility is a be all end all wonderful thing no matter what. And
Yes.
just to start opening your eyes to how the movement's happening, how mobility is occurring. Is it appropriate for that client? Do you need to limit it? And really helping that client develop range and strength, or I'm going to say range, but I say strength and support and stability through their whole range of motion.
Yep.
Rather than focusing on just kind of our end ranges, which we often do. So
No.
that's all.
Awesome. Awesome. That's exactly what I was going to say. Basically, is look, the body needs both stability and mobility.
Mm-hmm.
And I think the best thing you can do is assess where they are, assess where they need to be more mobile, assess where
Mm-hmm.
they already are too mobile, work on
Yep.
stabilizing that, and just seeing what looks normal and what doesn't. I think right now for us, it's a lot about our eyes, about our ears,
Mm-hmm.
because when you listen to someone walk, you can often hear a limp or something like that, or some disharmonious movement. So I think that's really important for us to develop as instructors. And I love your idea. I do it all the time and did it when I was younger. Just watch people. Just watch
Yep.
people.
Everywhere.
It's one of the best things that we can do.
Mm-hmm.
Well, thank you guys very much for joining us. Do us a favor, hit that like and subscribe button, share, comment, all that good stuff. We really, really appreciate it. It really comes in handy for our algorithms. We keep getting more people every week, and that's so exciting for us because it shows that people are listening, and hopefully you're learning a lot and you're able to take this into your practice. So do us a favor. If you like something, let us know. Hit us up, either DM us through Gmail. We will through DM us through Instagram, or email us at movingcombos@gmail.com, moving combos on Instagram. And yeah, that's the easiest way to get in touch with us. So we really appreciate it. And we appreciate every single one of you for listening. So for Nora St. John, I'm Brian Ritchie. We'll see y'all next week.
Thanks, guys.